Good evening and welcome you all. In Fogsi Presidential Initiative podcast series, Gyan Pravah episode 250. This is 250 is a big number and we are doing continuously is under the leadership of Dr. Sunita Tandulwadkar, our President Fogsi. An inspiring initiative by our President, which is the gift to just give the power to our wings. It is ज्ञान का बहता रोजाना एक नया अनोखा रंग. हर रात 8 बजे जुड़िए आप फॉक्सी के संग. Today our guest is Dr. Alka Barua. She is Chief Lead Abortion Rights and Access Portfolio of Common Health. I am honored to be part of this initiative under the leadership of President Fogsi Dr. Sunita Tandulwadkar Madam. She is a visionary who has redefined reproductive medicine with excellence and resilience and innovation. She is a pioneer in reproductive medicine, renowned for her groundbreaking achievement of delivering India's first stem cell baby and world's first at the age of 45 in 2018. She serves as a head of the Department of Gynae and Chief of IVF and Endoscopy Center, Ruby Hall Clinic, Pune, and is the founder and medical director of Solo Clinic IVF as well
Jyoti,
as...
it is your show with
Yes, madam, but still, I want to just convey.
Thank you. Thank
you. Alive is a state-of-art clinic. She is a founder and medical director of Alive, a stem cell research and application center, and one more center in Mumbai recently inaugurated, giving us all the world-class services about the regenerative medicine. Her leadership extends across prestigious platforms, currently as President Fogsi 2025, President-elect ISAR 2024-26, Founder President of the Society of Ovarian Rejuvenation in 23, with over 18 authored book, 85 scientific publications.
It is important to be a President Fogsi. This is a Fogsi project. Thank you so much.
Madam,
actually using kind words for us.
Madam, today, October 5, it is observed as the World Teachers Day, and additionally, it is observed as National Do Something Nice Day. So today I am so happy and humbled that two of the great people with me, both of you are just doing something good for other. Even Alka Barua madam, she is doing something good for the underprivileged persons for this abortion care access, and you are doing everything for the women health and all the gynecologists, madam.
Thank you, dear. Thank you so much. And Alka ji, as I just joined for 2 minutes to welcome you, it is very important that you are on the Fogsi platform, and it's our honor and pleasure to have you. This podcast series are fantabulous series. I don't know, today we are with 250, but when we will be 365, so much of intellectual property with 45 minutes to 60 minutes every day with faculty, from renowned faculty, not necessarily they will be on a maternal health, but anyone from spiritual, non-academic background also doing a very good work, maybe a politician, maybe the film actress, everyone is here to guide us and to take us. So I'm sure your and Jyoti's dialogue will be a wonderful thing and many more will enjoy. Thank you so much for being there on a Fogsi platform.
Thank you, madam. Thank you, madam. Thank you very
much. Our protocol is I join on the viewers link, ma'am, and I enjoy the dialogue. Thank you so much. Looking forward to see you sometimes in person.
Thank you. Thank you, madam. Today's topic is MTP Act and Conscientious Objection.
Oh my God, it will be of a great help to everyone. Yes. So just see to it that you send the link to all.
Yes.
Thank you. Thank you.
And our guest, Dr. Alka Barua, she is an independent consultant with an MD in pediatrics and a PhD in sociology with over 35 years of experience in public health research. She brings deep expertise in reproductive and child health, program evaluation, capacity building, action research, qualitative methodologies, and research ethics. Dr. Barua has served as a consultant to several national and international organizations, including the World Health Organization, International Planned Parenthood Federation, South Asia Region IPPF SARO, and Genetic Health Projects and CREA. She currently leads the Abortion Rights and Access Portfolio of Common Health, a coalition of nearly 400 individuals and the civil societies. Additionally, she serves as an advisory committee of the Save Abortion Advocacy Initiative. As we all know, India is having the best law for the MTP. India has Medical Termination Act, which is amended in 2021. It offers relatively progressive approach to abortion in the global context. When we see the in US or UK, we are far better than US and UK, and we are expanding access to safer procedure and incorporating key women's right principles. It aligns with global trends of liberalization by increasing the gestational age limit for 24 weeks for special categories like survivors of sexual assault in minors, removing marital status restriction for contraceptive failures, and establishing ground for abortion beyond 24 weeks due to substantial fetal abnormalities. This all makes the Indian law comparable to more liberal jurisdiction and addresses issues of stigma and uneven access to care, which remain challenges in the global landscape of the reproductive health. Alka madam, usually this podcast, it is not only seen by the gynecologist, it is seen by the common people, means the non-medical people, or the medical people other than the gynec fraternity also. Even all the IMA members, all the fraternity of the doctors. So we will not go in the detail of the MTP Act when it was done or amended or anything. Everybody is knowing our law is so liberal, Indian law is so liberal. So we are not going in the nitty-gritty of the MTP Act or, but just for the starting of this podcast, I just want to listen from you. What are the key provision of the MTP amended Act, not the old Act, amended Act, madam?
Yeah, sure. So, the key provisions under the amendment one was, of course, what you mentioned is that the gestational period was extended from 20 to 24 weeks. That also led to, rationalizing the opinion of service providers, in the sense earlier you needed one up to the gestational age of 12 and two from 12 to 20. Now it has been rationalized as one service provider up to 20 weeks and two service providers from 20 to 24 for the special category of women that you talked about, those who are survivors of rape, incest, or in case of minors, or in case of women facing some sort of emergency, reproductive emergency. Beyond 24 weeks, it has also mandated that a medical board of experts will be set up, which will be examining, reviewing the status of the person seeking termination and look at the presence of fetal anomaly or risk to the life of the woman. In such cases, actually, there is no gestational limit whatsoever. Also, what you mentioned is, the marital status requirement has been removed in the key provision. And last but not the least, what is very critical is that confidentiality, ensuring the confidentiality and privacy of the abortion seeker under the amended act has been integrated or enshrined so well that now there are penalties a person can be penalized for breaching confidentiality, both in terms of imprisonment as well as in terms of financial fine. So that's what the key provisions of the amendment are.
So, yes. So our key provisions are, they are not saying if the lady is adult, then there is no need to be asked that she is married or unmarried. There are so many things for rape victims or the rape survivors and minors. We actually, this MTP Act is very comprehensive, very liberated MTP Act. But still, many doctors, many gynecologists, they are not knowing the term conscientious objection. So, what it means by a conscientious objection in context of medical termination of pregnancy?
Basically, conscientious objection, the way it is defined is when a healthcare professional, be it a doctor or a nurse or a midwife, refuses to provide legitimate health services to which they are opposed on religious or moral grounds only, or because it is in conflict with their personal beliefs. It's not denial of services for any other reason. Conscientious objection is largely when the denial is based on your faith or your belief. So that is conscientious objection. It's very interesting. This term came out of army, military conscription, which was people refused in those days based on their religious beliefs. And that term now is being used in the healthcare setting, but with some issues or some problems.
So is it explicitly recognized in the MTP Act, madam?
No, it is not. But at the same time, I would also like to mention that it is not seen as an act of insubordination either, in the sense that it is neither recognized as something which is allowed or not allowed. When the MTP Act has specified the registered medical provision practitioners who can provide the services, it has also given to some extent a discretion to those service providers of not providing those services if the person doesn't fit into the criteria stipulated under the Act. So that, provision is also there in the MTP Act, but the conscientious objection part of it is not mentioned.
So in very easy terms, we can say just last week the Navratri, just last week we are having Navratri. So many doctors, they are saying we are not doing MTPs in the Navratri. So many other doctors, they are saying ki this we just came from the Hajj Yatra, so we will not provide the MTP. So does it mean you meant about this, no madam? This conscientious objection means this just about your faith that you are just saying no for the patient, obviously.
Yeah, so there is always this belief that it has to be a conscientious objection of a service provider can to some extent be ethically justified on the grounds of personal moral integrity, autonomy, or their religious beliefs, but it has to be balanced against their professional duties also, isn't it? The primary ethical obligation is to ensure patients' well-being, access to legal medical services, and ensuring that patients are not discriminated against. So allowing conscientious objection without limits can lead to delays, denials, and this is a very time-sensitive service. So in such cases, if you do have these concerns, if you do not want to provide the service, you have to have an alternative as to whether you want to refer the person to someone else.
You are having this specialty in this particular subject. So what are the ethical arguments in favor of allowing conscientious objection, madam?
Oh yeah, there are. The ethical arguments in favor of conscientious objection is, of course, the freedom of individual moral integrity, autonomy, freedom of conscience. We respect a person's right to act according to the deeply held religious beliefs or ethical beliefs. And, as I mentioned, when it came in the context of army, it was also seen as something which safeguards you against the potential abuse of state power or some coercion of any kind. But in this particular case, where it is a time-sensitive, legally available service in the country, there has to be some alternative available to women, because most of those women who we come across who suffer are from marginalized communities who do not have any other alternative. For example, you look at rural areas, there are just 2 OBGYs or only 2 service providers who are recognized for providing these services. And if they have conscientious objection to providing these services during a specific period or overall in general, where do these women go? Do they have any alternative? Yeah.
So, madam, there must be many criticism according this thing. So, what are the criticism of permitting conscientious objection in abortion care? Because we all know we are having the population, we are actually exceeding the population of many of the countries in the world. So, there are so many things associated with this particular conscientious objection. We are, when refusing the patient for MTP, we are not only refusing the patient, means denying the services to the patient, but side by side we are just not giving her space for her just mental health or physical health, or not for the we are not even going to commit the national goals for the maternal mortality or maternal morbidity just by not allowing the patient for going to MTP.
True. For example, if you permit conscientious objection and, these qualified service providers are not available, particularly in the areas where there are very few service providers, and this is a time-sensitive service, what happens is, what we have come across is it delays or it denial of service leads many of these women towards unsafe services. So, ultimately what happens, unsafe services have their own consequences. We have consistently said that about 8% of the maternal mortality is because of unsafe abortion, and it is something which is totally preventable. So in such circumstances, should it be allowed or should it be regulated to her? At the same time, ensuring that people do have a right to refuse services, but then should they be referring these cases as is done in many other countries?
Madam, you all are having so much data about all these services related problems also. Whenever actually we are refusing or we are accepting this type of things for the MTP, particularly for the MTP, what are the impact when we are just does conscientious objection? How does this impact on the safe abortion care services?
Well, as I mentioned, they end up going to all either unqualified providers or they take OTC drugs. One doesn't know is it necessarily the combi pack which they are taking or they are taking, because that is something which is given by the chemist. You look at what happens when they go to unqualified providers and end up with botched terminations. I think the data shows that with the advent of medical abortion pills, even if they are not supposed to be and they are available over the counter, the mortality due to unsafe abortion has definitely been, a morbidity, I would say, has been impacted. But at the same time, there are providers who believe that this is something which should not be available over the counter. The medical abortion pill. It's also illegal for them to be available over the counter. So for women to have safe services where they have counseling for medical abortion or where they are referred to another service provider who is qualified, you need to regulate conscientious objection.
The obligation remain with the doctors who refuses for this abortion services on the moral ground. Though there are no moral ground, madam, when we are the service providers, if the patient is coming to us, we have to just think like a doctor. Our ethical or ethnic practices, our religious practices, or even the social thinking we own by ourselves, we should keep this apart. As a doctor, we have to just provide the services to the patient if she is coming. But still, some doctors are saying on moral grounds, I will not do this MTP. So, what type of obligation remains with these doctors, madam?
When we do become doctors, we have something called medical ethics, which are defined by beneficence, autonomy, justice. These are sort of core principles of medical ethics. And what do they mean by that? Beneficence actually means you are acting in the best interest of the patient. Autonomy means you are sort of respecting the autonomy of the person who is seeking services. Autonomy to make informed decisions about own body, own health, where your own personal beliefs, your own moral sense does not override that of that patient's or the service seeker's choice. And justice, because we are talking about a system which demands fair and equal treatment. If it can be violated when conscientious objection disproportionately affects vulnerable people in the society, such as the poor, rural, or young women who have fewer alternatives. Those who are well-to-do, are rich, have means, in any case are able to get services from elsewhere. But this affects the poor people. And in this case, you have to think about, the basic principles of medical ethics that doctors have.
Madam, actually, we all are having just working nowadays. Everything is global. Actually, we all are having data from the US, UK, or the rest of the world also. So, how do you compare between the US or UK with the India about this particular topic, madam?
Well, in UK, conscientious objection was recognized under the Abortion Act of 1967. It allowed service providers to opt out of participating in providing abortion services on moral grounds, but they were legally required to refer the cases. Also, this conscientious objection was not allowed in cases of indirect service providers, that is nurses, midwives, it was not, and frontline workers. It was not allowed in case of institutions. It was allowed only in case of individuals, such as one hospital cannot refuse the service. An individual doctor in the institution can sort of avoid providing the service. In USA, well, in USA, as it is, as you know, the laws change according to the state. There is a federal law and there are state laws. So conscientious objection in many states is allowed, and healthcare providers can refuse to perform or assist in providing abortion services based on their religious or moral beliefs. And in some states in the US, even institutions are permitted conscientious objections, and they are under no obligation to provide reference. So in many ways, our law is much better. And if conscientious objection is somewhat, I'm not saying that it should be denied, but it is regulated to a certain extent. We have a much more flexible law. And
So in US and UK, they can deny because that is written in their own law. So, and there are terms and conditions applied. If you are denying, then what you have to do. So there are the clear-cut instruction given on the laws. Here we are in our law, there are no clear-cut instruction about denial of the services.
No.
So what role does the judiciary play in the balancing women's reproductive rights with doctors' moral beliefs?
Well, I don't know whether one should say that it's fortunate that such cases have not yet landed up in the court, and they shouldn't, because it's not such a big issue even today in India. There is no direct instance of cases in relation to conscientious objection that I'm aware of. But the judiciary, if you look at the rulings, there are different rulings, but nevertheless there are some very important or critical rulings that have upheld the reproductive autonomy as a right under Article 21 of Constitution. So it has emphasized the woman's right or the service seeker's right to make decisions about own body and pregnancy. So though conscientious objection is not formally recognized in Indian abortion law, the judiciary has prioritized women's access to safe and timely abortion services, and suggesting that ethical objections by healthcare providers should not become a barrier to service seeking.
So officially there are no cases in the judiciary. Officially we are not seeing so many cases, but in the day-to-day practice we are seeing the cases. In the day-to-day practices, the patients are coming and saying that particular doctor has said no. And by the time we are in the Indian scenario, it is not that much easy for a woman to go to the gynecologist clinic. If she is going to gynecologist clinic today and the gynecologist says, no, I am not providing you MTP services, then it may possible that woman cannot come again. It may possible if she goes again to her home, she cannot come next day. So and when she comes again after 1 month or 2 months or 3 months, we can just see she surpasses the gestational age limit of the abortion. Sometimes she comes at 28 weeks or 30 weeks, and we have to just say you have to continue with the pregnancy. Sometimes these patients, when the doctors refuses them, this patient goes to the quacks, this patient goes to the this unlicensed practitioners, or sometimes they land up with the morbidity, so much morbidity. They are taking pills, they are taking MTP services like DNC or ENC in the unauthorized places where I have seen so many septic abortion cases. I have seen so many product of conception remain there and the patient is bleeding and came in the 3 gram and 4 gram. So indirectly, though these are not actually written in any cases, there are no judiciary cases, but in the practice we are seeing when we are refusing the patient, what sort of things can happen. If the patient is the marginalized, means patient is from the marginalized community. If patient is from the well-off family, she can go next day also to the another doctor. But in general Indian scenario, in the rural population or in the urban population, if the patient is from the low socioeconomic group, once we are refusing the patient, she is going again to her own home and she is not actually turning up. These are the things we have seen in our practice, madam. What about you?
I must sort of make a point that, denial or referral on a legitimate ground, such as, if you are not qualified, if you do not have the requisite infrastructure, or any such thing is not conscientious objection. Conscientious objection is when you deny on grounds of your religious or faith-based beliefs. So that is conscientious
Yes,
objection.
the qualified doctor is denying the services on the religious or
Yes.
other grounds, but that's why the patients are going to unqualified
Yeah,
doctors.
that's true. That's true. We do come across many such cases. And in fact, we have come across cases who have gone up to 6 service providers, one after the other, and have ended up paying as much as 50,000 rupees for a termination of pregnancy. We have case studies, yes.
So it should be restricted or regulated in India. What are your take? When you are doing a lot of work in this subject, so you came across a lot of NGOs or even gynecologists like us or the pediatricians or many organizations are in your contact. So what do you personally just think about to just should we restrict it or regulate it?
If you ask us, as an organization, we in Common Health believe that yes, it has to be regulated in many ways. One is, of course, we need to have very clear guidelines also for doctors.
Like you said, no, madam, ki we have to be very particular about referring this patient.
Yes.
If you are not doing, you would have to refer her properly to a proper place.
Yes. So that those guidelines have to be in place as to what should the service provider do. For instance, you are saying that it's a conscientious objection which kicks in only when there is Navaratri, but it's not otherwise there.
Yes.
In such cases, there should be very clear guidelines that during this period, what is it that you're going to do to cases who come to you? So you refer those cases.
So this actually this type of objection apply to emergency cases where the woman's life is at risk. Just like if I am a gynecologist who is not going to do MTP at any cost. It is my belief, religious belief that I am not doing MTPs. And now the patient is coming to me and she is bleeding. She is just in complete abortion and she is bleeding. So how does it apply to these emergency cases?
Maybe I missed a point that even in countries where it is legally permitted, it is not permitted in cases of emergencies.
Okay.
So it does not apply there. You have to provide the service. And particularly, if you look at the WHO guidelines on when service providers have conscientious objection, it has very clearly specified that, these are not applicable in cases of emergency. These are not applicable. Conscientious objection is not permitted in public facilities.
So it is WHO says that you have to provide this objection or you have to just refer this patient properly, and the individual doctor can do this, but as a hospital, as an institution, there are no guidelines just to say that you can just refuse the patient. And if the doctor refuses the patient, what alternative this doctor should provide to the patient, madam?
One is, of course, provide the entire information about, one does not have conscientious objection to providing information, I hope. So, give the entire information that is relevant in case of any case which comes for termination of pregnancy. And then you give the referral, closest referral. It's not, you are sitting in, suppose I'm sitting in Pune and I give a referral to a doctor in Mumbai. No, the closest. Because it is seen to affect, as you yourself also mentioned, marginalized population the most. And they cannot have this kind of, it ends up being a barrier to their access to services. So you have to ensure that they get services.
Here we are talking about doctor denying the giving the services, but sometimes doctor is saying just go for the abortion, but the woman, which is the seeker, she is saying that she is denied abortion on conscientious objection grounds. There are so many cases when we are saying you have to go for abortion, you cannot just continue this pregnancy, you have to terminate this pregnancy, but the woman and their attendants or their family, they are just denying. So what are the legal consequences of these type of sequences?
Well, if you look at it, if we are talking about a woman's right to decide about her own body, her own pregnancy, it's her choice that she has decided, then as such, technically there are no repercussions for the doctor because it's something that she opted for. It's her choice. And that has to be at the center of any service provision, is what we talk about.
Madam, many times in the missed abortion cases or incomplete abortions or even in the inevitable abortions, when we just say the women, she may agree, yes, it may not continue. This pregnancy is just wasted pregnancy and we have to just do this. She has to just go for the abortion care services. But sometimes when we see the patient is pregnant, patient is coming with pregnancy and there is this very high blood pressure or patient is so much anemic and just doctor is thinking that this continuation of pregnancy may harm patient's mental and physical health, and then doctor is just trying to say कि just discontinue this pregnancy or just come in the pink of your health and just then plan a pregnancy. In our this year's presidential initiative is a Sampurna. Sampurna means adolescent to menopause, you have to provide Sampurna care of a woman. You have to just see everything. Means if patient is planning for, this woman is planning for pregnancy, she should know each and everything about her numbers like hemoglobin or sugar or even blood pressure or weight, and she should be totally fit to continue with the pregnancy or to plan with the pregnancy. So in such cases, when we are seeing that patient is not fit to continue the pregnancy, so we are just about to say that you just go and terminate the pregnancy, but all of a sudden all the family people, they are saying, no madam, you are advising wrong. At that position, circumstances, what the doctor should say? What are the legal aspect of this thing?
Actually, as I mentioned, it's her and her family's choice. You know, interestingly, motherhood in India, given our entire patriarchal society and the sort of importance of motherhood in that particular environment, you know, the socio-cultural dimensions of childbearing are often not taken into account, even when we make the law as well as when we provide the services. So, you know, however much you tell the woman about the risk to her or her family, their socio-cultural, you know, environment has a very major influence. So, there are efforts being made by organizations such as ours, where we are making people aware of the risks associated with unsafe abortion or, you know, the complications of pregnancy or the complications of unsafe abortion. So as long as you have given entire information and you have told her what her options are, ultimately it's her choice, so there should not be any legal implications for her.
So madam, the medical ethics may clash with this objection. So how do medical ethics clash with that? Because it is the ongoing process in our own mind also, in the patient mind also. We are just thinking, हमको करना है, नहीं करना है, करना चाहिए, नहीं करना चाहिए. So how do this medical ethics clash with the conscientious objection, madam?
Medical ethics clash, as I mentioned, is of course, you know, you
Yes,
are
autonomy of the patient.
autonomy. You are not respecting if you go ahead with what you think and do not respect her opinion.
Madam, may you just give any international or national example for this particular thing? Just to regulate this conscious objection.
Now, conscientious objection, in what sense? What example?
So just if you want to just regulate this thing, just like just if you want to just, I am refusing a patient, so just you want to give some example that the doctor should just give a proper referral. Is there any single case or any single example you can quote?
No, actually, you know, often what happens is these are not cases. Even in our own studies, we cannot document them as or name individuals.
There was one case in Ashta. I am from Madhya Pradesh. There was one case from Ashta. The father was the girl was the rape victim, and father was just going here and there for the abortion care services, and everybody was refusing. And the girl landed up in the 28 weeks of the pregnancy. and there was that time the amended act was not there, and they have to just continue with the pregnancy. And then afterwards he launched a complaint, and that case was in the Supreme Court, up to Supreme Court, and then the doctor was punished and with the fine and everything. Because there are so many things we are doing for the rape victims or the rape survivors or such type of pregnancy, and that girl has to just give birth of the kid. Who will raise the kid? Who will just take care of that kid? So any such type of cases in your practice you have seen?
Yeah, we have seen first of all, many of the rape cases are minors who are sent from pillar to post, service providers denying these services, though technically under the MTP Act, in the special category of women, these cases do fit in. So, there is every minor who comes with a pregnancy is, if you look at it legally, it's a rape because a minor's consent is not considered as a consent. So it's a rape in that way. So they come in the special category. They come in the legally mandated service provision. They come in that category. So, service provider who is qualified, who is recognized, who otherwise does not have conscientious objection related to service provision should not deny, and definitely not in the public sector, should not deny these services. So there could be legal repercussions in such cases if the person goes to the court.
So many times people say this gender discrimination is something different, sex determination is something different, rape is something different, domestic violence is something different. But being a gynecologist, being a pediatrician, doing so much work in your NGOs, you are knowing that everything is interconnected. Everything is interconnected. So can you just see that refusal to provide abortion services, it can be considered as a gender discrimination, madam?
Yeah, of course. And the reason is very simple, because it systematically restricts a woman's access to essential healthcare based on their reproductive role, something which only they have, isn't it? It denies a service only to women and people with capacity to become pregnant. Yes. Which is only these people require these services. You are actually denying services to a particular section of the population. And once you deny, it disproportionately burdens these women, limiting their autonomy, their bodily integrity, their ability to make decisions about their lives and their futures. And to a large extent, it also reinforces harmful gender norms for example, if a single woman or a minor comes with pregnancy, a moral judgment on their reproductive choices is something which you are reinforcing the gender norms. And these are often rooted in the patriarchal views about what is motherhood, what should a female sexuality be within the confines of marriage. And the last but very critical one is, once you deny these services, which lead to unsafe abortions or forced continuation of pregnancy or health risk, these are borne by a particular gender, isn't it? It's borne largely by women, it may affect the partner to some extent if the partner is perhaps sympathetic enough or not. But it's something which affects one particular gender specifically, and therefore it's an act which is related to gender issues or gender discrimination.
So in the next couple of years, we can just provide some data about this when we are refusing these services for the maternal mortality or morbidity, or in the septic abortions, or many things. Even our GDP goals we are just talking. We are having just these type of patient. They are, you told just 50,000 that patient just paid, and going for just 6 doctors and paying 50,000 for one MTP in even the rural area. This may affect the patient's pocket also, madam, and we are just saying no to this type of thing. Apart from all the discrimination, they are just having the loss of the finances also when they are going door to door to the other doctor. So in your opinion, should India include clear provisions on conscientious objection in the future amendments? Because recently it is amended in 2021, and it was actually, we all gynecologists are so happy, because it is not necessary, madam, ki all the time these girls which are coming to us are the married. But the lady coming to us at the age of 34 or 35, and then we are refusing her for the abortion services, saying that you are unmarried, I cannot provide. So we all are actually, when we saw the amended act, it is actually a very liberated act as per for doctors also, for the patients also, but still many gray areas are there. So what you just two, three provisions you want to just be amended in them, if any amendment in future.
More, it took 50 years to come up with such dramatic amendments.
Yes,
It's
ma'am.
not going to be that easy to come up with amendments that soon. But perhaps, guidelines for service providers.
Yes.
Uh, those will be pretty useful. For example, even if Fogsi takes that initiative, you do have your guidelines. But, that they define that under these circumstances, what is it that the provider should be doing. So that would come in very useful, and Foxy has that kind of reach within the policymaker community and others to ensure that it gets reflected even in the ministry guidelines. So those will be very useful. Conscientious objection, as I mentioned, guidelines of what should the person do if they have objection on religious and moral grounds. How should they refer? Where should they refer? What would be the cases? Some such, but I wonder whether conscientious objection is really on faith-based denials are such a big issue right now within the country.
Still, our MTP Act is a pro-doctor act. It is not pro-patient. It is a
No,
pro-doctor.
it's not.
Yes.
You can't have abortion on demand here. No.
Yes.
It's liberal, but it's liberal in the hands of the service providers.
Provider. So as PCPNDT Act, it is a pro-patient act or pro-bureaucracy act. As MTP Act is the pro-doctor act. So for you, MTP Act is the pro-choice or pro-regulation?
Pro-choice or pro-regulation?
Yes, ma'am.
Well, it's choice for the provider and regulation for the
patient. Yes. And we all know this amended MTP Act, we just discussed this maximum gestational age. Now to this question we all know, and still sometimes we are refusing, sometimes we are accepting. This conscientious objection, it is a right for a doctor or barrier for a woman, madam, when you're thinking.
Or what for a woman?
Right of a doctor or barrier for a woman?
It's both. It's right of the doctor, which can result in barrier for the woman if she is not referred, if she is not provided with an alternative.
Madam, in our socio-economic thinking in India, because we just say India is a mixed ethnic culture, we are having so many states with the different languages, different cultures. So when we say abortion is and if we have to fill in the blanks, abortion is a right, or abortion is a moral dilemma, or abortion is a medical procedure. If I go and ask to a general person.
I would like it to be a right, but in many situations, particularly in socio-cultural environment, it can be a moral dilemma for a person.
And for me as a doctor, it is a medical procedure only.
It should be a medical procedure like any other.
Yes.
You don't have law for most of the other procedures.
So in our private hospitals, be they allowed to refuse abortions on moral ground, madam?
No, the same thing applies as I mentioned earlier. The certified or recognized service providers or any service provider has the right.
Yes. Is India more liberal or restrictive compared to global abortion law?
Oh, we are fairly liberal in terms of our law, but a bit less liberal in terms of its actual translation at the ground level.
So now everything is going global. Everything is going global. So global trend is expanding abortion rights or restricting them? Expanding abortion rights or restricting them?
It depends on which country you look at. If you look at United States, it seems to be restricting abortion rights.
Yes.
And around the same time, we liberated it.
We are going to be liberated, and the US is going to be just saying there should not be abortion care services. So, Indian MTP Act better than US after Roe versus Wade reversal? Yes or no?
It is. It always was, and it continues to be so.
And abortion denial due to conscientious, justified or unjustified? As a doctor, madam, as a doctor.
I feel it's unjustified. If I look at the definition of conscientious objection in terms of faith, it's my personal opinion. I believe that if I have joined this profession, then my patient's well-being is my primary obligation.
Nothing is written in the MTP Act, official MTP Act in the Indian Gazette. And if the doctor refuses abortion, is referral mandatory? Yes or no in one word? Though it is not, never means nobody written, never means I have never seen in any act or any textbook or nothing. But as a doctor, when we are practicing in in any hospital or as a private practitioner, and if you are refusing, means if me refusing abortion, is referral mandatory, madam? Even if the no.
But I must, I must mention something which I find a little interesting is that when doctors who are approved or certified for provision of these services, it's not that doctors were pulled in, they came voluntarily for this particular recognition, isn't it, for as service provider? So once you have joined, you have sought that permission or the recognition as a service provider for abortion services. Where is the question of conscientious objection?
Yes, but actually we are having very progressive law, but there are some patches in this particular law, and every doctor is just taking care of their own, and they are just, when they are comfortable, they are doing abortions. When they are not comfortable, they are saying that today I will not provide this MTP. And even when the patients are coming, though there are a big thing written as a contraceptive failures or women's choice or women's physical or mental health, if they are harming, still as a doctor, when the patient is coming to us, the patient is having two previous girls, the previous two girl child, all of a sudden every doctor is thinking about the PCPNDT Act, and they are saying, "मैं तो abortion करती ही नहीं हूँ." What is your say about this?
It's very interesting. If you look at the PCPNDT Act, other than its preamble, it does not mention abortion. The Act penalizes sex determination and its disclosure, isn't it? It doesn't talk about abortion at all. Now, theoretically, if you look at it, women who have two daughters or who have undergone ultrasound, found a female fetus and have undergone abortion have as much violated the Act as those in whose case a male fetus was found and they continued with the pregnancy. Isn't it? Because determination is something which is and disclosing it is the violation of the Act. So, this is something which we never think about, that too is a violation. But coming to think of it, if we believe that it's a woman's choice and her right to her body, her decisions about her pregnancy, then it does become a little difficult when we talk about, abortion of a female fetus. It is something, it's an area of tension which needs to be sorted out. The root cause...
Root cause is just nobody wants to go to jail or nobody wants to go to just get the registration cancelled. Everybody is nowadays, it is a litigation prone era we are living. So everybody is thinking मेरे ऊपर मुसीबत क्यों आ रही है? And in our Indian scenario, being a doctor, we all are not having all the elite class patients. Most of our patients are from the rural or lower middle class or middle class families. When they just came to know, when they come to know just I am pregnant, and they are thinking to go to the doctors, already the 8 weeks, 12 weeks time is just surpassed. And when they just think about to just go for a sonography, it is about 11 to 12 to 13 weeks. And then doctor says, abhi main nahi karungi because this is the particular time when we can just determine the sex. So if the patient is coming to you at the gestational age limit of 6 weeks or 7 weeks or 8 weeks or 9 weeks, we are happily doing all service providers are happily doing the MTPs. But when the 12 weeks or 13 weeks this gestational age limit crosses, we usually says we are not doing the abortions. These are certain gray areas, and it may possible that patient she has not undergone the sex determination, but who wants to be in the any type of litigation?
No, I agree completely with you. We had done a study in Western Maharashtra where we had shown that service providers fear the scrutiny under the PCP Act so much that many of them refuse to provide second trimester terminations at all. So they stick to first trimester or refer the case to, or they ask, all kinds of permissions, all kinds of signatures, all kinds of, official requirements are there. So in the
So
whole
MTP,
process, what
MTP Act is saying no signature, means other than the patient, no signature requires.
Yes.
Still, we are taking so many signatures from the attendants, from everybody. We are just taking signs. So original MTP Act is not saying to take signature of the attendants. This is the thing. For you,
Even
who
today,
comes?
even the amended one doesn't say. Huh?
Yes, ma'am.
Sorry?
Who comes first? Patient's rights or doctor's beliefs?
Patients' rights.
And if I
Doctors
am the
are
only
service
doctor in some,
providers. No, in case you're likely to face some legal consequence. Particularly the one you mentioned, the fear of PCP Act, to some extent is also because the way it has been implemented. It's not necessarily, the way it was expected to be implemented. And that has what has caused problems.
so the woman's autonomy should be prevailed. But if doctor's conscience is saying, "Yeah, I don't want to do abortion," we have to just give a proper referral, proper advices,
That's it.
proper ifs and buts of the things. And if you are bold enough to say why you are not providing this service, you can just you can also just enumerate the causes why you are not providing this service. The patient is just coming to your door and she is believing on you. If you are properly guiding the patient, she will just listen to you. It is not like कि हमेशा गुस्सा होके जाएंगे. If you are just saying कि today this festival is there, I am not doing MTP, just go to my colleague, she may do. And you yourself can just ring a call to this your colleague and just ask, are you going to provide this service? Patient will also feel good that doctor is concerned about her health or her decision. But most of the time we are not doing these exercises. We frankly say no to the patient. No, I will not do. वो पेशेंट पूछती मैं आप कहाँ जाऊँ, तुम्हारी मर्जी कहाँ जाओ. This thing should not be done. We have to respect the patient's autonomy, women's right also. And as a woman, not as a doctor, as a woman, we should feel ये लेडी बहुत सारे हर्डल्स पार करके आपके क्लिनिक तक आई है, ये शायद कल नहीं आ पाएगी. There are so many pregnancies, they are the result of the domestic violences. So many pregnancies just they doesn't want to continue due to their financial issues or their household domestic violence issues, but they cannot say. एक बार हिम्मत करके आपके पास पेशेंट आई है, that particular time you should not refuse to provide them any services. That is what I think. What is your take on it?
No, I agree completely. And that's why I said that even if you have conscientious objection to provision of service, you should not have objection to provision of information. So, that entire information as to where she can go, the importance of time-sensitive nature of this particular service, as to, when you can go out of the stipulated time, gestational time period, and could be legitimately refused services. That also needs to be emphasized. So all information has to be given to the person who is seeking services.
Because, madam, it is not always the point for the married girls or married women. Most of the time, there are so many unmarried girls coming to us, and we are just seeing. If we say no, they can land up with the unqualified people also, and it will harm their physical or mental health also. So most of the time, as a gynecologist or as a ethics and medical legal committee chairperson, I just think we have no choice to say no. But still, if we are having some ethical ground, there are no moral ground to say no to the patient. If there is patient is sitting in front of you, there is no moral ground to say no. As a doctor, you have to say yes. But if there is some ethical means if you are having some religious things or you are just so many doctors. In my young age I just saw, madam, I am going under the infertility treatment, so I will not provide the MTP services. Few of my registrars, they are saying, madam, I am under the infertility treatment, I will not provide the this MTP services. So I can just say we have to just help them out, we have to just refer them out. This is the only thing we can do. And from just before logging it out, I just want you to say a few lines for all our viewers, gynecologists, non-gynecologists. What as a doctor, what as a woman, what as a service provider, and what as a citizen of India we can just say about this topic to our women.
Well, yes, as a service provider, once you have got the registration or approval as a service provider, you sought it. So you are morally obliged to provide that service. As a woman, it should be my right. Currently, it's not my right to demand a service. Currently, it's still dependent on the service provider. I would like it to be my right, because taking a decision of terminating a pregnancy is not an easy one. And if a woman has taken that decision, she has thought about it quite a bit. And that will. The other thing is, when the service providers decide on providing the services, they are not expected to look only at the current situation of the woman. In fact, if you look at the NTP Act, it also talks about considering not only the actual existing environment, but the foreseeable environment of the woman as well. So, you have to think about the woman's rights. So those are the two things. As a society, well, as a citizen of this country, I think our act is fairly liberal in its own right, if it is interpreted correctly and if it is implemented correctly. Let us first implement the law and get it translated into the services that women were expected to have under this act. And tomorrow then we can talk about perhaps, whether we need the law at all. Other many more serious services do not, services which have serious impact on the health of individuals do not necessarily have a law regulating them. So do we really need them? Can be a conversation at a later date. But right now, proper implementation of the act and abiding by the spirit of it, which was supposed to be safeguarding the woman's health.
Near future, the days are coming when the women can say the doctor is violating my rights. So we have to just provide. These are the days which we have to just see.
So one of the things many of our organizations are doing it. We have member organizations also. So what we are doing is, we within the legal boundaries of the act, we are telling communities and women about what are their entitlements under the Act. What is it that they should expect? And what are the service providers' obligations under the Act? So neither of them should have any, misconception about what they should get from the Act or what they should provide under the Act. This is the Act. This is how it should be implemented.
So my urge to all my gynec friends, just we have to stick to the word respectful abortion care. And it is every woman's right. If you are not feeling good to provide this type of services, at least we have to guide them. We can just use the word sisterhood. That particular woman is also just like our sister as a fellow woman. And as a doctor, we have to just provide all the things she wants. If there are some glitch, if we are not able to provide just due to your setup or your degree or whatever, if the patient is high risk patient and you are not able to provide at your setup, then she must know, she should know what reasons you are refusing. If these are the valid reason, you can just refer these patients or these women to the proper places. You should take the follow-ups also. We have to take the follow-ups also. It is just not like we have to just refer the patient to some hospital and we just balap choot gayi. These are we have to just long way to go for the respectful abortion care, respectful maternity care. And I hope you are doing so much work for madam, this particular thing. When I came to your contact, it was actually eye-opener for me also. I was just seeing everything as a gynecologist perspective. But I have never judged or never thought when you told me everything about this conscientious objection, that particular moment I thought, yes, in my practice many times I also refused some patients. And that time I was not thinking in that particular manner. But yes, when you just elaborated all the things and I came to know, it may happen to this patient. So after that, I was so careful, so conscious about saying no to the abortion care. And whenever, if I am saying no, it is mandatory to refer this patient to the proper hospital and to the proper colleague. Thank you, madam. Thank you very much, madam, for this very new topic for all our viewers.
Thank you so
And you
much.
just simplified each and everything for us. I am so thankful on behalf of Fogsi that you just agreed for becoming our guest, madam. Thank you. Thank you very much.